Welcome to the conference session titled Understanding Transplant Options. Thank you for joining us. My name is Alice Hauk, Senior Director of Patient and Professional Services at AAMD-SIF, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help us manage the incoming questions. Submit your entire question all at the same time, and please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. Richard Lin. Dr. Lin is an assistant attending in the adult BMT service and assistant member at Memorial Sloan Kettering Cancer Center, and he is an assistant professor of medicine at Weill Cornell Medical College. He was first driven to seek a cure in hematologic malignancies many years ago when his translational work in acute promyelocytic leukemia combined two targeted therapies to induce long-lasting disease remission. Since then, he has learned that hematopoietic cell transplant and cellular therapy often is the only curative option for most advanced hematologic malignancies. Now, his ultimate goals are to reduce treatment-related toxicities that limit their widespread use and to combine them rationally with other therapeutic modalities such as immunotherapy and targeted therapy to achieve a cure. With that said, welcome, Dr. Lin.
Thank you, Alice. And I want to welcome everyone to this session and want to thank you for the organizers and AAMDS Foundation for inviting me to speak. I will share my screen. Okay. Can you all see me? See the screen? Okay.
Not yet. You aren't screen sharing yet.
I'm sharing the screen.
Okay. Maybe try one more time.
Okay.
And just in presentation mode, and you're good to go. Perfect.
Okay, very good. Thank you, Adrian. So in this presentation, what I would like to do is to give you a brief overview of allogeneic transplantation, also known as donor transplantation, for patients with aplastic anemia, paroxysmal nocturnal hemoglobinuria, and MDS syndrome. I have no financial conflict of interest. I won't discuss any off-label medication use. And this presentation is for educational purposes, and please feel free to share. I'm going to discuss two parts related to donor transplantation. In the first part, I will briefly discuss what is donor transplantation, and importantly, how do we prepare a patient for transplantation. I will review the disease indication and its timing, the donor source, as well as patient preparation. I want to highlight from the beginning that those three key components are interconnected chains, so that all three of them have to be aligned together in order to proceed to transplantation. In the second part of my talk, I will review the complications and side effect of donor transplantation, as well as a long-term expectation and quality of life. I will briefly stop after the first part to see whether I can answer any questions before we discuss the second part. which is actually the more scary part of the stem cell transplant. So in this diagram, it reveals the concept of donor stem cell transplantation. Essentially, the stem cells is removed from the donor. In this particular scenario, the stem cells were removed from the donor via apheresis machine. You can think about apheresis machine as similar to a dialysis machine, where they filter a person's blood and return the blood back to them. And in the process, isolate the stem cells, and the stem cells shown here can be stored. This is usually an outpatient procedure, and usually lasts about 1 or 2 days, and usually has very minimal side effects for the donor. When the stem cells are ready, the patient will receive treatment to destroy blood-forming cells. This process is what we call conditioning chemotherapy. Sometimes it also involves radiation. As you can see from this middle diagram, the patient will be given chemotherapy and or radiation therapy through the IV, and it will destroy the original or the patient's own blood-forming cells in their bone marrow. And then after that, the patient will receive the previous isolated stem cells via transfusion. And the stem cells would circulate in the patient body and find the patient bone marrow to settle in. That process takes about 2 weeks. So why do we do stem cell transplantation? What is the therapeutic mechanism? The stem cell transplant was developed over 6 decades ago in order to combat diseases such as acute myeloid leukemia, as well as bone marrow failure syndromes such as aplastic anemia. The first and the most important concept of stem cell transplant as a therapy is to replace a patient's diseased bone marrow. And this is the fast-acting therapeutic benefits. As you know, many of us have hematopoietic stem cells in our body. They have the ability to both renew themselves as well as to differentiate into other different cell types. In this case, this is the white cells, neutrophils, and lymphocytes, which have disease-fighting abilities. This is your red cells, and this is your platelet. We require all of those blood components to function normally. But in diseases such as MDS or aplastic anemia, and our marrow is not working properly. So the first and the most important therapeutic mechanism for stem cell transplant is to replace the diseased bone marrow with the new donor bone marrow stem cells so that they can establish new blood-forming cells in the body. The second mechanism for the therapy for the donor transplantation as a therapy is to establish a new immune system. And this is the slow mechanism happens after the stem cell transplant. As many of us have different immune cells in the body, they are B cells, T cells, they can have innate immune cells such as NK cells and dendritic cells. And those cells have a great capability to fight infections, pathogens, as well as to defend our body against cancer. However, when you have aplastic or MDS, your body immune system is not working properly, and thus they cannot get rid of the diseased cells, which is why the new donor's immune system would be the second most important mechanism for the therapeutic benefits. When the new donor's immune system established, sometimes take months or even years, they will become the new body, your body's new immune system, so that it can protect against infections as well as cancer. So again, the two major therapeutic mechanisms for donor transplantation is one, to establish your body's new blood-forming cells, and two, to establish a new immune system to protect you and to act as your guardian angel. So how do we prepare oneself to undergo donor transplantation? So in this diagram, I want to highlight the three most important components. One is disease control. Second is the selection of donors. And the third is optimization of the patient. Please keep in mind those three components are very tightly connected in that all three of them have to be aligned reasonably well with each other before one can proceed to transplantation and have a good outcome. If you have only one or two of those three components aligned, occasionally we go for transplant even in those situations, but the outcome will be suboptimal. I will explain each of those components in detail. The first of which will be controlling your disease. So let's go over the indication for transplant for aplastic anemia. For patients with acquired severe aplastic anemia, initial consideration for transplant is based on patient's age. When the patient is age 40 years or younger, upfront donor transplant should be considered if they have assembling donors. The MRD stands for matched related donor. In this case, is one of the potential your siblings. If you don't have such matched siblings, but have unrelated donors from the registry, then transplantation should also be considered. Only if you don't have either matched related donor or matched unrelated donor, then the younger patient should be considered immune suppressive therapy, IST. For older patients, on the other hand, this is applicable not only to patients aged over 40, aged from 40 to 60, but also applicable to patient age over 60. Their initial therapy should be considered for immunosuppressive therapy. And if they don't have response, or after they respond, they develop clonal evolution, in this case, develop into other hematological malignancies such as MDS or AML. In those type of situations, they will be considered for transplantation. So the difference is for the young patient, they will be considered for transplant upfront. For the older patient, they usually are considered immunosuppressive therapy first before they consider transplantation. It's highlighted here that for selected patient who is in very good shape and who have matched the sibling, even though they're older, they could be considered for transplantation. In the case of PNH, the role of transplantation is constantly evolving. With the approval of complement inhibitor eculizumab, many of the patients with PNH will be started on eculizumab first before they are considered for transplantation when you don't have adequate response from eculizumab. In some situations, the PNH may be associated with another bone marrow disorder, such as myeloid malignancies, AMLs, or MDS. In that particular situation, you could consider treatment for specific underlying bone marrow disorders. And if you don't have adequate response, to go toward donor transplantation. In the case of MDS, donor stem cell transplantation is probably the most widely used therapeutic modality. In this simplified diagram, I divide MDS into a high risk, low risk. The focus of this talk is not about the risk stratification of the MDS, But I just want to mention the high-risk MDS are usually associated with many genetic changes, many mutations, thus making those diseases very aggressive, have a high risk of transformation into AML. For those type of patients who are considered high risk, we usually consider transplantation as the initial therapy. If they have available donors, if the patient is still in reasonable shape to undergo the procedure. If they are not considered transplant candidates, in this case, patient can receive different type of chemotherapy. However, it should be noted none of the other treatment at this stage have any potential for cure. For the low-risk patients, if they have been transfusion dependent, has many high-risk mutations, or they are not responding to the initial therapy, they could also be considered for transplant. As a matter of fact, many low-risk patients would progress to the high-risk disease after several years. That's the natural history of many low-risk MDS. One unique aspect of MDS is that it predominantly affects older patients. So in this table on the left-hand side, I describe the age of onsets for several hematological malignancies. As you can see, MDS patients have a median age of onset in their 70s and above, and transplant remains the only curative therapy for this entity. Consistent with those demographics, we have seen an increase in older patients undergoing transplantation in the United States. On the right-hand side, I want you to focus on the bottom figure. This is data from a registry for all the transplant patients in the United States. And they are divided into different age groups. If you look at this age group of 65 years and older, this is the blue columns here. You see an increased percentage of older patients among the transplant recipients in the US over the years. A similar way to look at this is to look at the indications of transplantation for different diseases. Traditionally, we consider allogeneic donor transplantation in patients with AML, ALL, MDS, and lymphomas. And as you can see from this registry study, looking at the trend of usage over the last 2 decades. As you can see here, AML remained the top indications, but its usage has been leveled off in recent years. And so is the case of ALL. In contrary, when you look at this light blue line, which is patient with MDS and myeloproliferative disorders, you have seen a steady increase of transplantation utilization in this group of patients. So this data suggests that we're increasingly using transplant as a way to cure those patients. Now, the next question becomes, what happens if you compare patients who go through transplant and patients who don't go to the transplant, especially in older patients where transplantation has not traditionally been considered possible. I'm showing here 2 most recent important studies looking at examining this question. On the left-hand side, it's a large registry trial of over close to 400 patients. What they did is they took older MDS patients between the age of 60 and 75, and they look at to see whether they have donors, in this case, matched donors. So either the matched siblings or matched unrelated donors. And the patient who have donors, they will be asked to proceed to transplantation. This is the blue line on top. For patients whom there's no donor identified, they will be asked to continue on supportive care therapy or low intensity chemotherapy. The primary outcome of this comparison is a 3-year overall survival. As you can see here, the patients with donor who undergo transplantation have significantly improved overall survival at 3 years, which is 47.9%, compared to the patient without donors, 26.6%. On the right-hand side, it's a similar study, but it's done in Europe. It showed a similar improvement of survival for patients who have donors and proceeded to transplantation, which is the red line here. And the blue line are the patients who without donors and continued on azacitidine chemotherapy. Now, I circled these two areas of survival curves because I want to highlight the important message here. This improvement in survival, it really happens after some time have passed. As you can see, the curve didn't get separated in the beginning. As a matter of fact, in this case, the curve even reversed in the beginning. In this case, the first year, in this case, the first 6 to 9 months. So the reason for this is because transplantation has some associated intrinsic risk. So even though over time, it wins out against no transplant, but at the beginning, it does have some immediate procedure-related risk, which balance out its potential benefit. I'll come back to this particular point a little bit later when we discuss the complications and the side effect of transplant, so that you will understand a little bit more about why this is the case, that in the first few months, even the first year, there's no such survival benefits. So the second part, I want to focus on the donor selection part. So in order for a donor stem cells to engraft in the bone marrow, it requires a matching at HLA genes. So the HLA gene stands for human leukocyte antigen. It is a cluster of 6 different genes. There are actually more, but for the purpose of transplantation, those are 6 essential genes: A, B, C, class 1, or DR, DQ, DP, class 2. All 6 genes are located in chromosome 6 in this region. As a result, those 6 genes are usually inherited together. This is what we call the haplotype. For the purpose of matching for donor transplantation, you only need matching for A, B, and C, and DR. And the DP and DQ are of less importance. Because each of us have 2 chromosomes, so that's why each of us will have 2 different haplotypes of different configurations of those 4 genes. So on the right side, I showed you here the inheritance of those haplotypes and why we're looking for match the donors first in the siblings. So let's say this is you. So you're A, and you have 2 HLA haplotypes. One of them obviously came from your dad, the blue column here, and the other, the purple one, has to come from your mom. So let's say you have 3 siblings. You have 1 sister, 2 brothers, and you can, because each of your parents have 2 different haplotypes, you can see the combinations of haplotypes among all your siblings. So if you are the patient, you're asking one of your siblings the question, which one of you will be my match? So if that were the case, you're looking for someone who has to have the same half from your dad and the same half from your mom. So that is 25% of chance that one of your siblings will be a complete match with you. there's also a 25% chance your sibling will be a completely opposite of you. It will basically get exactly the opposite half of the exact opposite haplotype from your mom and from your dad and from your mom. And then there are also two siblings that could have the possibility of 50% match. In this case, they got the same one from your dad, but a different one from your mom, or the same one from your mom, but different one from your dad. So that's why each of your siblings have 25% chance to be a match with you. So let's say if you don't have a matched sibling donor, the next step is to look at for a worldwide registry of over 33 million voluntary donors. And those are the people who have donated their DNA to be kept in this centralized bank so that if there's a patient who needs a match, they can search the database for potential matches. And that's what we call the matched unrelated donors. You can think about them as a secret family members, perhaps many generations up the family trees. Unfortunately, if you do not have a matched sibling donors or matched unrelated donors, then there are several alternative options. The three alternative donor options are either mismatched unrelated donors, which means the matching is not 100% compared to this one. It's perhaps matching at 80, 85%, or even 75%. Or the other option is to use umbilical cord blood as a donor source. In this case, those cord blood units are actually stored in the central bank throughout the world. They can be delivered to the institution where you undergo transplantation. And then lastly, a new group of donor is gaining a lot of popularity. It's what we call the haploidentical donors. It's essentially either your children or your sibling who is not 100% matched with you, but have half of the haplotype matched. So in this case, they are considered 50% match. Because of the new development in transplant technology, as well as improve the supportive care, we can do this type of transplant as well. The outcome of haploidentical transplant is approaching the outcome for matched sibling donors and matched unrelated donors. I should say that nowadays we consider the matched sibling donors and matched unrelated donors have very much similar outcomes. So what are pros and cons of using each donor sources? So in this diagram, I highlighted a few important pros and cons. When you talk about a matched sibling donors, it's traditionally considered a gold standard in transplantation because it's your family. They're usually rapidly available. They usually reconstitute in the patient bone marrow very rapidly. I apologize. And the cons is that, as I mentioned before, it's only 25% chance your sibling will be a match. And the other important issue is that when you're older, your siblings are likely to be older, and some of them have comorbidities that preventing them from actually donating. Haploidentical donors, also because they're from your family, they could be readily available. You can get to transplant quicker. They are less expensive, but sometimes they have increased risk of infections and slightly increased risk of graft failure. For the unrelated donors, the outcome, like I said, is similar to HLA matched sibling donors. They also can rapidly reconstitute the bone marrow. Their cons is, unfortunately, availability is quite varied. And in order to achieve unrelated donors from the registry, sometimes it takes 2 to 3 months. In the case of cord blood, it's usually very much available, and you can get to transplant quicker. there's no donor involved because they're taken from the umbilical cord when the babies were delivered, and they're stored in the cord blood bank. So you do not need to actually identify a donor. Their disadvantage is that they usually have very low cell numbers, and their immune reconstitution and engraftment is quite slow, and the whole process is quite expensive. So we usually reserve the cord blood transplantation for younger patients who are traditionally considered minorities and who don't have the matched unrelated donor or matched sibling donors. For older patients, because the time it takes for engraft and increased risk for infection, we usually do not use the cord blood as a donor source. So I want to speak briefly about these issues of donor match. As I mentioned before, when we search the worldwide registry for potential donors, we have found there's such a ethnic diversity, as shown in this study done over 7 years ago. If you're white Caucasian, you have a 77% chance to identify a matched unrelated donor from the registry worldwide. In contrast, on the other extreme, if you're Black or African American, there's only 23% chance to identify such a donor, and slightly better for the Asian, Pacific, or Hispanics. The reason for this are twofold. One is traditionally there are more volunteers from the white Caucasian groups, and thus the representation is heavily favored in this group. And the second reason is that African Americans tend to have very rare haplotypes, like the HLA haplotype we discussed before. Because of that, the chance of finding a match is lower. We have been undertaking significant effort worldwide to increase the representation of minorities in the donor registry. You probably have seen many of those blood or donor drives throughout the country and throughout the world. So briefly, to discuss a little bit about the process of donation. There are 3 ways of donating stem cells. One is the donor can actually go to the operating room or perform repeated bone marrow biopsy, sometimes in the order of hundreds times, but obviously a patient will be under anesthesia, they will not know. And the stem cells isolate from the bone marrow and then give to the patient. The advantage of this process is that it's done in 1 day, usually about 2 to 3 hours, and it does not involve any medications. And the donor usually return to the work in the next day or 2. There are minimal pain and discomfort. The complication rate from the operation is minimal. The advantage of using the bone marrow source for the patient is that there's slightly decreased risk of long-term graft versus host disease if you use the bone marrow as a source. The second source of donation is from peripheral blood, just like I showed in the previous picture, where the patient is hooked up to an apheresis machine. Their blood is filtered through the machine where the stem cells is isolated, and the blood returned to you. In this particular case, the process may take 1 or 2 days. The advantage of this process is that the patient is conscious, the donor is conscious, and it does not involve operation or under general anesthesia. The disadvantage is that you have to give yourself a medication to stimulate the release of stem cells into your blood. And those medications are Neupogen and sometimes also Mozobil to mobilize the stem cells. So there's some small side effect from those injection medications. For the patient perspective, the peripheral blood stem cells has been shown to engraft faster. However, they have slightly increased risk of chronic GVHD later on, which we will talk about. The third source of stem cell donation is from the cord blood, as I mentioned before. So lastly, I would like to talk about patient optimization. So how do we know a person is a candidate for transplantation? We traditionally assess patients' candidacy for transplantation use this comorbidity index. The comorbidity index is a composition of certain different organ system impairments. Each impairments are weighted for certain scores from 1 to 2 to 3, and we add up all the impairment as a total score. As you can see, this takes into the consideration of cardiac, GI, endocrine, neurological, psychiatric, liver, obesity, infections, rheumatologic, GI again, renal, pulmonary, liver, and the heart, and the lung. So all those organs will be thoroughly assessed before transplantation to evaluate your candidacy. I should point out that for patients with severe renal, pulmonary, heart, and liver comorbidities, they usually have very high scores and are traditionally not considered for transplant as a transplant candidate. We usually say if a patient has 3 points and above on this index, they're at a high risk for transplant-associated complications. If you're having a score of over 7, 8, we usually not consider them for transplantation. On the right-hand side, beside comorbidities, we also consider a person's function. In this case, we use a simple scale. In this case, from 0 to 5, 5 is dead, 0 is considered fully active, continue to carry on all normal activities, and 1 is restricted in some way from disease or treatment, and 3 is quite limited, where patients are laying in bed more than 50% of the time. And I should say that traditionally, we only transplant patients in those 2 categories. But however, nowadays, we have found ways to improve patient performance status, such as that patients who are ambulatory and capable of self-care, but unable to carry out any work activities, and we can improve and optimize their function before proceeding to transplantation. Again, there are some unique challenges for older patients. As mentioned before, many of those MDS patients are older and they have a lot of issues with increased comorbidities. They could have impaired function, cognition, mobility. They could have malnutrition and using many medications, all of which could contribute to what we call the frailty phenotype. However, older patients also tend to have a higher risk of disease. They have increased sensitivity to regimen-related toxicity, as well as the development of geriatric syndromes. Older patients also tend to have older caregivers and suboptimal social support. So all of which contribute to the challenges we face when consider transplantation for older adults. In this particular study, I want to highlight some recent new development in optimizing and preparing older patients for transplantation. As you can see from this illustration, you could have an older patient who is not functionally considered robust. You can say could be one of the categories in the category 2. And those patients, when they are thoroughly assessed, both their physical function as well as cognitive function, they could undergo intensive rehabilitation, including physical therapy, occupational therapy, nutritional support, consultation, social support, And with those intensive management and optimization, many of them could become a suitable candidate to go to transplant. In this particular study, they show that this comprehensive optimization program improves decreased inpatient deaths, nursing home admission, decreased non-relapse mortality, and increased survival. So again, going back to our 3 interconnected chains, the disease control, the donor selection, and the patient optimization, only when all 3 of them are considered aligned most of the time, then a person can be considered to be on the launching pad for transplantation. So that's the key message, is that the 3 things, the 3 components has to be prepared and optimized simultaneously and aligned. So this is the first part of talk. Before I discuss the second part of the talk, which is much more scary, I want to see whether there's any questions. I can answer them now for the first part.
Yes, Dr. Lin, we do have a few questions.
Go ahead.
One is, does MDS arising from aplastic anemia have a worse prognosis than de novo MDS?
So that's a good question. And there's several studies have shown that MDS can derive from aplastic anemia. This is the process we call the clonal evolution. Sometimes at the time of diagnosis, you could have an aplastic anemia clone. At the times of diagnosis of MDS, you could have an aplastic anemia clone. But long-standing aplastic anemia could also evolve into MDS because they accumulate certain genetic changes and become more aggressive. In that particular case, the prognosis of that particular type of MDS is worse than the de novo MDS. And the transplantation is indicated in that situation.
Another question, are patients with a PNH clone more difficult or at greater risk of complications during transplant? Is there a specific protocol for patients with PNH, or is it similar to the aplastic anemia protocol?
So that's a great question. I don't think there's an increased risk for PNH per se in terms of transplant process. However, as I've shown before, most of the patients nowadays are considered eculizumab first before they're considered for transplantation. So that nowadays we rarely transplant patients with PNH anymore because the eculizumab is very effective. However, in rare situations where the PNH is not responsive to eculizumab, we do take them to transplantation. And there are some recent studies to suggest that we can even use eculizumab after transplant to optimize patient outcome to reduce their GVHD.
Thank you. One of the diagrams that you had on the slide did not include patients between age 20 and 40. What would be your recommendation for a 25-year-old female with only a half-matched sibling, but has a full unrelated donor with a partial response from HATG and tacrolimus 1 year out from diagnosis?
So actually, I think that diagram, if I go back, I believe it's under the age of 40. So this particular patient should be considered, this should be considered in this particular category. Unfortunately, if the patient doesn't have a matched sibling donors, then it's reasonable to consider an immunosuppressive therapy. I would say if you have another matched unrelated donor, you should consider to go this route for matched unrelated donor HCT. And this particular limitation of age 20 is not absolute. It's more about the donor availability, which is the rate limiting factor. As you can see from this comparison of different donors, right? The unrelated donors, their outcome is relatively similar to similar donor, but the main issue is the delay and availability, right? Because the unrelated donors, it takes somewhere 3 months to get their stem cells. If this is your brother or sister, obviously you can get it relatively soon. So I think in this particular case, I would suggest to evaluate the availability of that unrelated donor and to proceed to transplantation. For younger patients, the role of immunotherapy, immunosuppressive therapy is really not long-term, because many of those patients, even if they're on immunosuppressive therapy, eventually they will develop genetic abnormalities and they will require transplantation anyway.
Thank you. Another question. Is it common to be administered chemotherapy immediately after transplant to kill any remaining cancer that may have survived the transplant?
Actually, so that's a good question too. It's usually used before the transplantation. The transplantation, if I understand correctly, you're referring to the infusion of actual stem cells. And in this case, we give them chemotherapy to both prepare themselves as well as to kill the remaining cancer cells. So if we go back to this diagram, this is where the chemotherapy or radiation therapy is given. It's right before the patient receives stem cells. And the goal of this chemotherapy is to both empty a person's bone marrow so that they can accept the new stem cells, but also this chemotherapy would have effect to kill any remaining cancer cells you may have. Immediately post-transplant, we sometimes give a different type of chemotherapy to reduce graft versus host disease, but we do not give chemotherapy immediately after you receive the stem cells in order to kill any remaining cancer cells. Is it here?
Thank you. And one more question before we go on to the second part of your presentation. Do we need to be revaccinated after autologous transplant?
The answer is yes. I think they're both, if the vaccination, you can think about there are different vaccinations. Obviously for flu vaccines and COVID vaccines, it probably you need to be getting them yearly based on what's available evidence now. And you will also be vaccinated for all the childhood diseases such as Haemophilus, measles, chickenpox, etc., usually at 1 year post-transplant. One thing about the COVID vaccine specifically is that you really have to wait until your B cells start to come back after either autologous or allogeneic transplantation before considering immunization.
Those are all of the questions so far, so you can go ahead with the next part of your presentation.
Okay, very good. So the next part is the shorter part, although it's the more scary part, so I had to warn all of you. And so we talk about how to prepare a patient for transplantation. And now it comes time for you actually to go to transplantation. So what's the actual process looks like? So in this illustration, assuming you're ready, you have all the things sorted out, you have your physical condition optimized, you have your disease controlled, and you have donors and stem cells ready. You'll be admitted to the hospital, and you'll be starting with several days of chemotherapy plus minus radiation, depending on the regimen you're used. The goal of those conditioning regimen is to get rid of your previous stem cells or bone marrow, as well as killing any remaining bad cells in the body. And then on day 0, you get your stem cells from the donors. And then the next phase is the waiting period, usually in the first 2-3 weeks. So this waiting period is for the new donor stem cells to settle in to your bone marrow and to start growing. And this is the part where you're the most vulnerable because you do not have any white cells, red cells, or platelet, you'll be dependent on transfusion of red cells and platelet and waiting for the new donor cells to grow in. So this is where you are most vulnerable. There could be early complications during this period from chemotherapy-related complications to complication related to medication to prevent GVHD. And once the donor cells start coming in, there could be also complications such as graft versus host disease, which we'll explain a little bit later. And once you reach this point, 100 days, we call that your first major milestone. This is where supposedly the donor has started to establish their footprints in your bone marrow. So they're starting to produce all the essential blood cells. But keep in mind, we talk about the two roles of transplant is to establish a new blood forming system, as well as a new immune system. At this stage, the new immune system hasn't been there yet. It's only the blood forming system that's coming on board at this stage. The immune system will start to develop somewhere from 6 months to a year. So this is the scary part of the donor stem cell transplant. The major toxicity are listed here. Number one is toxicities related to conditioning chemotherapy, radiation, or anti-rejection medications. You could have significant mucositis, GI toxicities. You could have significant problems with organ injuries. That's why we have a checklist. We look at different organs before you go to transplant. If you already have very damaged organs, lung, kidney, liver, then we don't think you can actually withstand the transplant process. For example, is that patient who has end-stage renal disease on dialysis, we traditionally consider them not a transplant candidate. You could have hematological side effects such as bleeding. And the second major side effect is the graft rejection. This is more common in the early days of transplantation. However, in the recent years, this rarely happens. About 1 to 2% for matched-related donors and unrelated donors who are matched. It's a little bit higher in the haploidentical donors. However, I should say in the case of aplastic anemia, there's a slightly increased risk of graft rejection, about 5 to 10%, because of their underlying disease biology. And the third major complication is infections, which we'll discuss a little bit more. And then the fourth one is graft versus host disease. We'll discuss that a little bit later as well. So this illustration is about the timing of the development of GI complications in relation to the timing of stem cell infusion, as well as different stage after transplant. As you can see here, the early stage, the first a few weeks after the stem cell infusion, you could have nausea, vomiting, could have mucositis, could have liver problems from drug toxicity, diarrhea. And then as time goes on, other things become more important, such as graft versus host disease, infections causing GI side effect, reactivation of viruses. And then as time goes on, after 100 days to after a year, you could have things related to the graft versus host disease in the GI system and liver system. So it's important to think about different complications along this timeline, because there are distinct patterns of complications, both from the organ toxicity perspective, as well from infection perspective, which is illustrated in this paragraph, this figure. So in this illustration, it describes phases of immune suppression as well as associated optimistic infection. So the immune suppression means that after transplant, your immune system is not going to be returned to normal until at least 6 months to a year, like I described to you before, right? The second mechanism of donor transplant is to establish a new immune system. However, that takes about somewhere 6 to 9 months even a year to do it. So before that, the patients are quite immune compromised. They have low lymphocytes. At the beginning, before engraftment, they have low white cell count. They have low immunoglobulins. Because of those immune system defects, as well as other complications such as mucositis and diarrhea, low platelet, as well as GVHD, all of this contribute to the development of all these infections. So in this illustration, and this row is high incidence infections. And this row here is low incidence of infections. As you can see here, again, based on different timelines, post-transplant, you have a different patterns of infection, starting from HSV infections, adenovirus infections, CMVs, chickenpox, and then all the fungal infections here, and the bacterial infections here in the early period. And the low incidence infection, including pneumocystis, encapsulated bacteria, as well as respiratory viruses. So those are, a lot of those infections are not commonly seen in immunocompetent individuals like you and I, but more commonly seen in patients who are immune compromised after transplant. As you can see, sometimes those immune compromise can last as long as 6 to 9 months. More specific to type of infections, again, starting from day 0 to the early period and to the 3 months, 100 to the 1 year, you can see here in the early period, there's a lot of gram-positive bacteria and a lot of gram-negative bacteria. And then later on is encapsulated bacteria. And for the viruses, in the intermediate period, there's a lot of reactivation of the CMV, VZV, as well as EBV. And then obviously there's a lot of fungal infections. They are predominantly in the early and intermediate periods. They are in the later part, the most common fungal infection is pneumocystis. I should mention that even though all the infections are very scary, and we do provide infection preventive medications from day 0. So you'll be on antibacterial prophylaxis prevention medications, antiviral prevention medications, antifungal preventive medications. However, even with preventive medications, there are still breakthrough infections. That's why we still see those particular incidents of infection. So lastly, I want to talk about this unique complications of transplantation. It's called the graft versus host disease. So you can think about of your graft, in this case, as your children, even though it could be matched with you 10 of 10 or 8 of 8, 10 of 10 or 12 out of 12 match, but still could have some issues settling in your body. In this case, you're the host. Because of this fighting, it generates this syndrome that's very unique to transplantation. It's called the graft versus host disease. And acute graft versus host disease happens after transplantation and within the first 3 to 6 months. It can manifest as a lot of skin rashes and skin erythema and a lot of diarrhea in the intestine and liver as well. And it looks like this under a microscope on the skin. The treatment usually consisted with steroids and many other medications. It's usually treatable, but it's quite common. Sometimes happens 30% to 60% of the time, but most of them are mild, can be treated with steroids as well as other medications. However, in rare cases, somewhere between 5 to 15% of the times, those can be very advanced and severe, can be fatal as well. The second form of graft versus host disease is what we call the chronic graft versus host disease. It happens after about 6 to 9 months after transplantation and can last until several years after transplantation. Its main manifestation is actually a skin fiber. It's it's a fibrotic process, manifest in the skin as those skin fibrosis, depigmentations, and the gum depigmentation, fibrosis, as well as you can see here, loss of nails, and fibrosis in the lung, and fibrosis in the eye. This is fibrosis in the intestine. So the process of chronic graft-versus-host disease is a slight different from the acute graft-versus-host disease we just saw. This is more inflammation. This is more fibrosis. The treatment of chronic graft-versus-host disease is still steroid, as well as many other new medications. Most of the time they can be treated. Again, there's a small percentage of patients, 5 to 10%. They can be very severe and prove to be fatal. So I mentioned about all 4 major complications of transplantation. What about the long-term side effects and long-term complications of transplant? Unfortunately, even 5, 10 years after you receive the donor transplant, there still could be various complications. In this illustration, I highlighted many potential complications related to specific organs. You can see in the CNS system, you can have anxiety, depression, post-traumatic stress disorder, neurocognitive deficit. In the lung, you can have cryptogenic organizing pneumonia and different GVHD type of syndrome. You could have kidney problems, and you could have iron overload, osteoporosis, and endocrine dysfunctions such as thyroid and gonadal dysfunctions, diabetes. And then you can develop secondary cancers. Most commonly are skin cancers. You could have problems with the heart, cardiovascular disease, hypertension, heart failure, as well as liver disease, all of which require meticulous surveillance from both the transplant physician, your primary care physician, as well as survivorship programs. I should mention that most of the transplant centers in the country have very comprehensive long-term survivorship management programs so that we can identify those problems early on and intervene early on. And lastly, I want to mention a little bit about quality of life. This is potentially important for many patients, as well as older, especially older individuals. As you can see here, we go through the transplantation process, so it's a recovery and reintegration. This could be taking about a year, 9 months to a year. And the quality of life obviously relate to patient's age, comorbidities, conditioning regimen, their support system, as well as the development of GVHD. But in general, you can expect that in the transplant period, you have predominantly physical symptoms, fatigue and sleep disorders, and they will gradually reduce as you through the recovery and will be essentially gone by the time, hopefully a year, when you reintegrate yourself into a normal life. And so it's a psychological symptoms. And you have increased concerns over social function, role function, and sexual functions. But the general pattern is that you should expect immediate post-transplant period, you who have predominant physical and psychosocial symptoms, they will be gradually reduced during the process of recovery. And hopefully by the end of 1 year, your quality of life will pretty much return to close to normal before transplant. So again, I want to remind you about this paragraph and these 2 studies. Remember, I circled these 2 parts and I said I'll come back to this. So now that I talk about the complications, the immediate complications after transplant, its reduction in quality of life, now you should start to appreciate why this survival curve separate only after about 6 to 9 months. It's because the transplant carries this early mortality, the early risk. That's why in the beginning, you will not see the benefit of transplant over non-transplant among those patients. only if you survive this period of complication, and later on, you will see the separation of those two curves, which you will be deriving the most benefit from transplantation. But one has to realize there is this early period of a risk and the reduction of quality of life you have to be aware of. So finally, I want to tell you a little bit about we as transplant physicians, how we do to improve the outcomes of patients with those diseases over the years. I'm showing here our national registry studies of all the patients undergoing transplantation for aplastic anemia, age 18 years or older, over the last few decades. As you can see here, the top blue dotted lines are patients who are transplanted from 2016 to 2018. If you compare them to the earlier transplant period, all the way to the early 2000s, you see a significant improvement in survival for those patients. And now we can expect for patients with aplastic anemia who undergo transplantation, they should expect a 3-year overall survival of close to 90%. So this is a significant improvement over a 20-year period. And this is mainly as a result of improved transplantation platform, technology, improve the donor options, as well as improve the supportive care. So we are making significant progress for transplantation for aplastic anemia. And the similar can be said about MDS as well. As you can see here, this is a similar graph as the aplastic anemia. However, we're far away from the 90% or 85% achieved with aplastic anemia. We can say now the 3-year overall survival for patients who are transplanted for MDS will be 50–55%. And obviously, this is the population average. For each individual, the risk could be higher, the risk could, or the survival could be higher or to be lower. But again, this tells us that we are making significant progress for patients with MDS and aplastic anemia. So my take-home point is the donor stem cell transplantation requires meticulous planning, collaboration, and a commitment from both patients and clinicians. As I mentioned before, it's a 3 interconnected chains. They all have to be perfectly aligned together in order to achieve the best transplant outcomes. The donor transplant outcomes are rapidly improving for aplastic anemia MDS with better supportive care, broadened donor options, and optimization strategies. I want to mention that the older patients are the fastest growing population who may benefit from this curative option, and they will benefit from start early with transplant consultation, assess the donor option, evaluate their candidacy, and most importantly, to understand the risk, benefit, and the logistic requirements associated with transplantation. And this is a review article we wrote recently and will be published next month. And we talk about how to consider 4 essential aspects of transplantation, in this case for older patients, in order to achieve the optimal outcome. This includes the patient intrinsic factors, such as their own motivation, physiological aging, their ecosystem of support, caregivers, and financial support, as well as their disease management and the transplant and design and optimal transplant platform. All 4 of them will work together to improve an outcome for transplantation. So with this, I want to take any questions you may have. And if you want to email me, I have an email here. Please feel free as well. Thank you again.
Thank you, Dr. Lin. We have a couple of questions. In general, when should a patient begin their search for a donor?
So the search of donor usually start with consultation with a transplant physician. And obviously, at which time we don't know 100% whether you are going to be a candidate or not. but most of the transplant physician will evaluate your donor situation at that time so that you have the option to know whether you have a matched sibling or matched unrelated or other potential sources such as your children as haploidentified donors.
Thank you. We have a question from a patient also asking, do you recommend egg retrieval prior to transplant for aplastic anemia in a young female patient?
The answer is yes. I usually advise people for fertility preservation before transplant, before to start any chemotherapy.
Thank you. And you mentioned toward the end of the presentation now about the extensive support that a transplant patient needs. Can you elaborate a bit more on what types of support a patient needs post-transplant?
So that's a very good question. There are several different layers of support. The most important or the first layer of support is caregiver. In the immediate post-transplant period, we as a center has a requirement of a caregiver for up to 100 days. And those caregivers usually are required to stay with patient 24/7. And obviously the period the patient in the hospital, the first 3-4 weeks in the hospital, you usually don't need a caregiver. So usually the months 2 and the months 3, you need a caregiver to stay with you 24/7. You don't have to be a medical caregiver in that you have to give medications, take vitals. You don't need that, but someone, most of the time is a family, friends, to help you with errands, doing laundries, cooking, accompanying you to the appointments, and most importantly, call for help if there's any medical emergencies or complications after you are discharged. And the second layer of support is usually related to the aspect of financial support, as well as support from your family in terms of long-term functioning independently in the home. So what that means is that obviously your insurance will cover most of the expense, but there are still instances where you need to travel and you need to buy medications. Some of them have high co-pays, and there are situations where you may have to undergo certain procedures where there's co-pay. So there is financial assistance program, but sometimes it does also call for some financial resources out of pocket. And the long-term speaking, the family support and living situations is also important because, as I mentioned before, you are not considered immune competent or close to immune competent for at least 6 to 9 months after transplant. So before that period, you really should have a very relatively clean living environment and with the capability to be isolated if needed. And that requires a lot in terms of your living arrangement. So those are the things we would consider as well.
Thank you. Do you know of any transplant patients post-MDS that have lived 10, 15 to 20 years after transplant?
Oh, so that's a great question. So I want to go back to this graph, right? So as you can see here, I only, this figure only draw 5 years, but the curve is flattened after that, which means if the patient achieve a remission at 2 years, which means at the 2-year mark, they are considered free of disease. They usually can maintain long-term remission, which means they could be considered cured, especially after 5 years. I can tell you the curves over there is going to be flat, which means they are long-term survivals. We have a lot of patients who transplanted for MDS who lives 5, 10, 20, or even 30 years. So That's the goal of the transplantation, is to achieve a cure. And it is the only therapeutic modality that can do that.
And one final question, does allogeneic transplant increase risk for AML?
So it's actually, the answer is no. The allogeneic transplantation is used to treat AML. So when you had AML, which is a similar type of myeloid disease as MDS, it's even more aggressive. So the treatment for that is chemotherapy and then allogeneic transplantation to achieve, again, a long-term cure. However, there's a very rare incidences. When I say rare, I mean, if it's even less than 0.1% of the times, you could develop donor-derived leukemias, which means that the donor, unknown to us, will have mutations in their stem cells who have the potential to develop into AML. I have to say, I have seen maybe 1 or 2 cases in the last 5 to 10 years in our institution, but again, it's very rare.
Thank you, Dr. Lin, for sharing your time and expertise with us today.
Thank you, and enjoy the rest of your weekend.
If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call the AAMDSIF helpline at 800-747-2820, extension 2, or submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 38 years. This concludes our educational conference session, but we hope you will join us for the support group starting at 3 p.m. Eastern. Thank you.